Can you see the slides that I'm sharing?
Yes, we can.
Okay, good. Hello, thanks, John, for the introduction. I'm calling to you from Cardiff, where I work as a senior clinical scientist. I won't say the rest because John has done more than enough on this. And today's talk, well, we had the title, but the key things that the talk will focus on is AI enhanced care and the disclosure of this information about the use of AI in healthcare and the consent process for the patient. Now, I will apologize for any dodgy puns during the presentation. I also have some pop culture references that some of my younger colleagues didn't get at all, but hopefully John will get them. And yeah, so I'll start by talking, well, I'll first mention something that the WHO stated a couple years back, and then I'll go a bit through the law of informed consent. And then I'll talk a bit about the philosophical, let's call them reasons why we might want to disclose upfront the use of AI in healthcare, but also the objections to these arguments. And then we'll move a bit through a couple of thought experiments and things like that. And I think I might muddy the water more than clarify it, but hopefully it will be of some interest. And I know that I'll be jumping sometimes back and forth between some concepts, but I thought a lot about how to structure this presentation, and I think you're probably getting the best out of all the bad options for it. But I hope you enjoy it. So the first thing I wanted to start with is something that the WHO stated like 3 years back or so on the topic of AI use in healthcare. And they said that the use of machine learning algorithm diagnosis and prognosis and treatment plans should be incorporated into the consent process, and that essential services should not be circumscribed or denied if an individual withholds consent. And then he stated that there is no precedent for seeking the consent of patients to use technologies for diagnosis and treatment. Nevertheless, the use of AI in medicine and failure to disclose its use could challenge the core of informed consent.
Michal, sorry to interrupt your flow there at all. Were you trying to change the slides? Because at the moment we're still just seeing the introduction slides.
Oh, do you? Let me try again.
Now, we can now see the second slide.
Is it moving?
No, you might be. Maybe are you sharing the wrong screen?
No, I'm sharing the right screen, except
right now that's just changed to Sylvester Stallone.
Okay. If I'm changing them here, does it work?
Yes.
Can I interrupt? I think you ought to be in slideshow. You're in editing mode at the moment.
Yes, but I think if I go into slideshow, then it's not moving between the slides.
That you are moving between the slides on that, so we'll stick with that.
Well, we'll stick with that. Okay, sorry for that. We had a minor IT issue with updating Teams on this computer. Anyway, yeah. So what was I? Okay. So I think the main thing that I want to challenge is those statements by the WHO and just show how they relate to the issue of informed consent. So now we'll move on to law, and I hope it will not be a too dreadful section. And I'll start first by talking a bit about consent law in general in healthcare, and then we'll move a bit to the fascinating topic of GDPR. So probably like the key piece of the key ruling that kind of dictates how we approach patient consent is the Montgomery case that happened about 2015. It's on the slide. But it was very significant, though in a sense it only affirmed what the GMC already recommended doctors to do. And actually Montgomery in the end, because of this, became a lawyer herself, and the case revolved around consent in pregnancy. But what's important to highlight is that as a result of this, it has been established that there's both a subjective and an objective standard in the UK with gaining patient consent, because there's this standard that you should tell a patient whatever a reasonable patient in that circumstance would attach significance to with regards to risk. But there's also a look at the particular patient. So if you know something about the specific patient that they value, that they would attach significance to it, you should disclose those risks as well. So for example, if you have a musician and you're discussing with them putting in a grommet in their ear that has a small risk of infection, that has a risk of affecting their hearing, you might not necessarily disclose that risk to every patient, but you should to this specific patient because it's important for them. And there's also, and Montgomery also stated that there's a duty to disclose any material risks involved in the treatment and any reasonably alternatives or variants to those treatments. And it builds a bit on the Birch case, which established that the patient has a right to know with what alternative interventions are there. And I guess the two main things that we learned from these cases is that the emphasis is on risks, but also on reasonable alternatives in the context of treatment. And I think this theme of risk and that theme of reasonable alternatives will appear a couple of times in my talk. So if we moved to risk, which the medical law refers to, I don't think it's like obviously clear what it means, because there's a physical aspects of risk, that you can have the risk of infection or risk of that happening, whatever. But there's also like this broader theme that we talk about, when dealing with patient consent. And those things relate to what you can see as a spectrum of opinion and philosophical or religious belief. Because, and I'll return to that later, so if you knew that somebody was averse to AI, would you treat that as an opinion or as a phobia, or would you treat it any differently to a vegan objecting, for example, to have porcine gelatin components in a medical product that you wish to use during the procedure? And the same thing for a Muslim patient. How do you conceive risk in this situation? Because it's not a straightforward risk that something will go wrong in the sense of infection and so forth. So do we need to look at patient consent and AI like just as a whole, or do we really need to focus on individual case-by-case scenarios? So is it the objective or the subjective standard with regards to consent that we're thinking around here? But there's also other more or less important legislation relating to patient consent. So there's the Chatterton case, and that largely talks about having to give patients specific enough information for it to count as informed rather than just real consent. And this is important because failure to obtain real consent can raise claims to battery, whereas failure to gain informed consent can raise claims to negligence. And it's probably a bit easier in the UK in the sense that if you're in the US, consent is given for a specific individual to perform, for example, surgery, whereas in the UK, even in the private healthcare setting, that's not the case. So there is a bit of a difference about how specific you need to be. but there's also the Gallardo case, and that talks about the fact that information needs to be given at all stages of care, because there are risks related to things that can happen after an intervention, such as cancer recurrence. But one of the important things that the judge stated in this case is that, you know, bad communication risks losing the patient's trust and confidence, and that the patient's right to be informed is not respected. So there's a bit more to what we communicate with patients than just the, you know, bare bones fact whether we've actually gained proper consent from the patient or not. And again, this theme on what, you know, whether the Mental Capacity Act is really that relevant here or not is a bit of a debate, but it also highlights the importance of good communication with the patient. So I think that there's more than the law that points at than just the risks. But now let's look a bit at the GDPR and what it says with regards to automated processing of data, which is processing that occurs without meaningful human involvement. So data subjects must be informed about automated decision making relating to their data. And there is, broadly speaking, a right not be subject to decisions based solely on automated processing, including profiling, even when such automated decision making is permitted. And Article 22 grants some exceptions to these, but with regards to healthcare, but these focus on situations when consent to such automation has been explicitly granted, or when there is substantial public interest and there are some appropriate safeguards put in place. Now, an important thing to remember is that for the purposes of what's mostly happening today, we're not really talking about such automated processing of data, because there's usually, hopefully, meaningful human involvement in the process. But anyway, there are also Article 21 provides broad rights to object to automated decision making. And there's the Recital 71 relating to profiling that also talks about the right to challenge automated decisions. But the state of recitals is somehow unclear, and how much weight do they have. And there's also Recital 60, which suggests that there's an obligation for disclosure, even if there is meaningful impact from clinicians. Now, one of the things that's important to remember also with regards to GDPR and patient consent is that they're not quite the same. It's actually probably easier in a way to gain patient consent for a procedure than it is in some cases to gain consent under GDPR. It might even be potentially impossible. So, for example, if AI became standard of care, then perhaps clinicians might not wish to undertake activities which fall below the standard of care, so they would refuse to perform certain activities unless AI wasn't involved on them. And under GDPR, the threat that might not be given, if it's not, let's call it AI enhanced, might violate the freely given aspect of consent. And that's just below is just a citation to the paper by Morby. But you know, there are also similar implications for using digital health records, in the sense that there's probably in many places no reasonable alternative to it that would be easily implemented in an institution. So this point kind of goes beyond AI in itself. So now that I've bored you a bit with the law and how it relates to informed consent, we'll talk a bit more about the philosophical foundations of consent. So the law aside, why is it important to seek consent? Now, the Stanford Encyclopedia of Philosophy gives 7 reasons for this. I think perhaps some of those could collapse into each other. But broadly speaking, there's this issue of protection of people from abuse, the right of people to autonomy, to self-expression, and there's also an element of creating trust between parties. And actually, Pellegrino and Tomasma, who don't specifically work on AI, but they worked a lot in bioethics, talk about this concept of beneficence and trust. So how the clinician healthcare system relates with a patient, and how patients come in this unequal relation, in this situation of unequal relationship of power to a clinician or a healthcare organization, and expect trust in those people or those systems to provide them appropriate care. And this theme will come back later in a moment as well. Haferle recently published rebuttals to four arguments that people could use to insist on disclosing upfront and seeking explicit patient consent for using AI technologies in their care. So I'll present these four, but I've tweaked them a bit and added a bit from myself as well. But the first such argument why you might want to seek explicit consent for AI-enhanced healthcare, is that patients need to consent to risks. So going back to the risks topic from the law, there are various risks that you could associate with the use of AI, such as adversarial attacks, problems with the algorithms, generalization, robustness, and their bias. But the question is, do we over-exaggerate the risks? So, for example, adversarial attacks are mainly used for insurance fraud and are easily detected. Also, if we talk about digital risks, we do not tend to talk about the risks of having electronic patient records and ransomware attacks. Moreover, risk is low if AI is placed in the appropriate context of healthcare. So if AI is not the sole decision maker, but is used by the healthcare team and there's input from the multidisciplinary team on any decisions, then the risk of AI doing something wrong is lower. And in this case, if we're seeking consent from patients, like, is there a possibility that we just want to shift the responsibility to the patient rather than, if anything goes wrong with the AI, rather than the organizations taking responsibility for making sure they're using their technologies properly? And risks, and some of the risks are also mitigated by post-deployment surveillance, post-code explanations, and model cards. And then another theme that relates to risk is that we tend to talk a lot about algorithmic bias. But do we talk as much about clinician bias, and which one is the more important to take into account? And I'll return to that a bit later. And then the last point with regards to risks is whether the risks associated with AI are the type of risks that we would usually expect to be disclosed with regards to other aspects of care. And again, I will talk about that a bit later. But going back to, sorry, I had a picture of data here, but going back to whether to the risk of privacy and AI, it's probably more important to think about the fact that most of the sampled hospitals in one study failed to implement basic security and privacy measures consistent with their digitization level. So overly focusing on AI might be used a bit as a smokescreen or as a distraction from other problems with regards to the digitalization of the healthcare system. And again, just to highlight the issue of risk of consent. If a treatment is really associated with great risks, would you even offer it to a patient, or do you just seek their consent and absolve yourself or your organization from those risks? So that might not be, consent. That's not how consent should be used. And we talk a lot about informed consent and disclosures, but actually, it's not just informed consent, it's free and informed consent. And what alternatives are we giving patients to ensure that the choices that they're making are not that coerced? Obviously, it's a tricky question because all different things are associated with risks, and not every risk is, is thought about as a coercive force if there's no viable alternative. Just because you have financial risks for buying one item and there's no alternative item doesn't mean you're going to buy it, because it simply might not be worth the money. But I guess we see healthcare a bit differently, that it's like an essential service. So we might be a bit more keen on trying to actually ensure that choice for patients is available. Another argument that Hatherley discusses is the rights-based argument. And that focuses on the fact that there's some kind of fundamental right to refuse. And in the weak version, it requires that the decision is solely made by an AI, which we know it generally doesn't tend to be. But in the strong version, it involves input, just some input from an AI. So if there is a fundamental right to refuse, if patients have rational concerns, these might not relate at all to risk to the patient themselves. So for example, if people just want to ensure that there are vacancies available in the healthcare system for new healthcare staff, they might want to avoid AI-enhanced healthcare because they want more people to be employed doing those tasks manually. Let's call it the solidarity argument. And if we talk about that there is some kind of fundamental right to refuse, then that seems to be a rational reason. But in practice, like certain disclosures and guaranteeing that you might have an AI-free process might be too demanding for institutions to have. And I'll talk about a bit later about the case of biochemistry labs, because automated processes are just so embedded in diagnostics that it would be nigh impossible to facilitate an AI-free process. And also, with regards to this, while patients have a right to refuse for any reason, if they're competent, that doesn't mean that we have to disclose everything to those patients. So, for example, if you had a patient that was averse to people of a certain sexuality, that wouldn't necessarily place an obligation on the clinicians to disclose that fact. So it's not necessarily the case that all things are, upfront disclosable, even if patients might be averse to certain things. The next argument is the materiality argument, and the materiality argument just says that there's something crucial about the fact that AI is used in a healthcare process that's crucial for the patient to make a decision. So, for example, if there's a negative hype around AI, think about Skynet type scenarios from Terminator, then patients perhaps might be averse. But if there's a general aversion to AI and clinicians are also averse to it, then algorithmic aversion is a double-edged sword because it ensures that clinicians don't blindly follow AI recommendations. So you know that a lot of the risks related to the use of AI wouldn't materialize. Moreover, we generally don't ask clinicians about their sources of information. And again, I'll talk about this a bit more later, but if a patient was interested whether the clinician got this particular piece of data or of information from a AI, would they ask them in what journal or in what circumstances did they learn something else about their care? Patients don't tend to quiz clinicians about from which textbook did you learn this fact, or which consultant did tell you that when you were a trainee, or other things like that. The other argument against making upfront disclosures about AI is that patients' preference change over time. So even if, let's say, now most people wanted to know, soon that might not be the case. But the counter argument is that obviously we're dealing with both a reasonable patient standard and a specific patient standard we're making our healthcare disclosures. And again, it's uncertain whether all those pieces of information relate to law, to risk, because if they don't, then perhaps we don't have to disclose them because they're not risk related. But as I said, it's a bit difficult sometimes to ascertain what is the risk. But because we generally accept that it's there's risks that are important, but broader personal values that the patient adopts. And the last argument with which Hatterley deals with is the autonomy argument. And it presupposes that there's this shared decision-making process, this kind of benefits and trust that I mentioned earlier, which balances patient consumerism and paternalism of the clinicians. And the challenge to this process is that AI might have embedded values. So, for example, an AI might be designed to maximize length of life over quality of life, and that's already a value that's embedded within the system. But clinicians also have values when they present and how they present options to patients, and we generally accept them as fine as long as as they're not forced onto patients, but are like passive values expressed by, let's say, the clinician and can be discussed, and a patient can make a decision based on that. The other thing relating to the autonomy argument, that there's opacity in AI which precludes explanations, but obviously upfront disclosure of the fact that AI is involved in a care process doesn't eliminate opacity at all. And on the other hand, clinicians are often opaque as well. They sometimes don't know why they would want to do this, or they're not conscious really about the source of their knowledge. So yeah. And just to enforce that point, if you think about statements such as not trained on a diverse population cannot explain why knowledge based on skew studies makes mistake and does not perform all the time according to specs, well, it can probably apply as much to AI as to healthcare professionals, because the skew studies that have been used to train healthcare professionals, and we know like the easiest examples are how on skin cancer conditions where it was highlighted that the models don't identify well skin cancer in patients with darker skin, but neither did clinicians, because they often weren't trained on whether on the population or appropriate text that allowed them to obtain these skills. So we're not necessarily talking here about any new risk with regards to that. As to the explainability, well, with regards to AI, there's a debate about how much right there is to there. Again, the Recital 71 of the GDPR says that there is a right to explain an explanation of the decision reached after such assessments and to challenge the decision. And Articles 13 to 15 clearly provide the right to meaningful information about the logic involved and envisaged consequences. So there, even with like opaque AI, there's hopefully an ability to provide a generic explanation, but not necessarily the specifics. But so it was the case for many years with things like selective serotonin reuptake inhibitors, nitrous oxide, and paracetamol. We knew why. We knew that they worked. We had the studies to confirm the reliability, but we didn't necessarily know the mechanisms of why they acted. And while that might be not an ideal state, and that ideally we want to know why things work, and generally we seem to be happy with knowing whether things work or they don't. And that's the key standard that we've been using in healthcare for a long time. And as to the level of explanation provided, if you think about a junior doctor or resident doctor, as I think the term recently changed, getting advice from a senior, like a consultant, or a generalist getting advice from a specialist, for example, from microbiology for which antibiotic to prescribe, there's a lot of opaqueness on the side of the resident doctor, on the generalist, as to why the specialist has necessarily made those decisions. And sometimes people make decisions based on experience or on hunches that they have. But if you know that your instincts are generally correct, even if you can't exactly figure out why they are correct, it doesn't mean that you necessarily shouldn't trust them. That obviously doesn't mean that we shouldn't be skeptical about these things at all. But it's not a reason to dismiss them. Now, one of the claims of the WHO was there was no precedent for seeking consent of patients to the use of technologies for diagnosis or treatment. Now, if we're talking about something like the Doctor from Star Trek Voyager using a sophisticated piece of technology, or the surgical pod from Prometheus, then perhaps not. But actually, we seek consent from patients to the use of diagnosis or treatment processes that involve technologies all the time. So think about surgery. And there are multiple technologies that are used during this process. From the tools that the surgeons use, like, do patients tend to inquire about them? Do they tend to ask, how much evidence has NICE got on the use of these devices or drugs during those procedures? Anesthetic machines have their own algorithms. There are about, at least like 3 different modalities for measuring cardiac output from a patient, including calibrated, uncalibrated methods, that use various algorithms, and as well as the use of ultrasound that, might optimize the waveform or whatnot, that the people who use these things probably don't know in a nitty-gritty fashion, but still use them daily. And even syringe drivers often have drug libraries in them and stuff like that, and are more automated than perhaps we think there are. Again, use of ventilators, the various modalities, the differences between manufacturers, transducers, they use algorithms, with them, or even things like taking blood samples for analysis. And I would have thought most clinicians using them don't know how they exactly work, how they communicate with the rest of the hospital data network, and so forth. Yet somehow we managed, or have been at least trying to gain consent for these procedures for a very long time. So to say that there's no precedent for it, I don't think it's just a correct statement. And obviously, the more technologies are used, the harder it is for any one professional to explain them. Now, how much a patient can take during a consent process, that would be rather overwhelming if we tried to explain how all these different things worked. And another statement by the World Health Organization was that essential services should not be circumscribed or denied if an individual withholds consent. Now think about a blood sample again that gets sent to the main labs, where most of the analyzers are automated. Would we really have the capacity to perform all these tests manually if patients objected to the use of robotics or AI or automation of any sort? Well, probably not. I don't even know whether we have the capacity to perform some of these tests manually at all in most places. So it's almost impossible to run a hospital or whatever without these services. So I don't think it's realistic to expect that we can always accommodate for people who don't like certain processes being carried in a specific way. So for example, think about a prospective case where we have some piece of technology that allows non-specialists to diagnose DVTs. And the process, let's say, proves to be clinically effective, cost-saving, and becomes the standard of care. Again, to reiterate my earlier point, while courts might not force doctors to give a specific treatment that they wish that the doctors believe is not beneficial to the patients, and there in principle is a right/obligation to transfer a patient to another practitioner who might provide such care, there might simply not be any practitioner willing to practice beyond what's regarded as the standard of care. If we moved back a bit in history and thought that a patient wanted to be, rather than receiving modern day treatment for something, to ask us to apply leeches to them because they trusted more in treatments with a long history, we wouldn't probably think that that was a particularly sane idea. And then the next statement from the World Health Organization is that the use of AI in medicine and failure to disclose its use could challenge the core of informed consent and wider public trust in healthcare. Now, as I mentioned earlier, I think sometimes it might be the case that there's limits to the alternatives that patients can have, which will obviously affect their freedom to give informed consent in those situations. And freedom is as important as being informed if we're looking at what the consent in clinical practice is. So I think my reflection on this is that it wouldn't be so much that the failure to disclose the involvement of AI would challenge the core of informed consent in the sense that it would bring something new, but it might relate to the fact that we're simply not giving patients enough information to start with about the various complexities of their healthcare. But that's just one possible interpretation about it. The other way to look at this is that we have to be reasonable about how much we can tell patients because of time and because of what they can understand. And I don't think many people think that overly long consent forms are particularly easy to understand or useful in such situations. Now, there are some potential different reasons to seek informed consent from patients when when using AI enhanced care. And the first one might be something like the fact that we might have like learning AI systems that as more patients are treated, they become better, they update automatically whatever you want to put in that bracket. And we buy those systems from private companies, and they're just getting more and more money out of the fact that they're learning on these patients, and these patients don't want to give their data for those purposes. But the counter to this is that, well, NHS already employs, locum/agency staff or whatever. And if these staff learn more by working in the hospital, those NHS organizations might be more keen on, again, hiring these healthcare staff because they're getting in better what they do. Yet nobody seems to object to the fact that locum or bank staff are learning as they gain more experience. There's another argument that I wanted to highlight, and it relates to democracy. What's the public view? Perhaps if most people think that we should be making such disclosures, then we just simply should. PricewaterhouseCoopers conducted a survey in 2017, looking at the willingness and unwillingness of people to have AI or robotics used in their healthcare. Well, unsurprisingly, somehow it turned out that the younger you are, the more willing you were, and the older you were, the more unwilling. But also interestingly, from at least the countries that they've put on the graphs, UK seemed to be the most unwilling country for having, intelligent healthcare in smartphones or in the care of their loved ones used. And the same with regards to the use of robotics. So perhaps a reasonable patient in the UK has some fear or skepticism regarding AI and robotics, and that should be our general assumption. Moreover, the Health Foundation presented some data this summer, and it showed, how much support is there from the NHS staff and public of the use of AI in patient care on administrative purposes. NHS staff was more keen on it than the members of the public. The only thing that members of the public seem to let the AI do by itself is to create a letter of appointment, a letter. And then the question was asked exactly about the issue of disclosure of information, whether AI has been used in care or not. And most people answered that they would want to have that information given. But just because most people want something isn't necessarily a good reason to do it. Most people probably don't read terms and conditions, and we don't necessarily regard that as a good reason not to have terms and conditions stated, because that information plays a variety of roles, including, if some kind of legal shenanigans were to happen because of a complaint and stuff like that. Though I already previously cautioned about the use of consent as a shield. But perhaps we're looking at this slightly wrong. Perhaps consent is just a thing that we're talking about a lot, and disclosure is is also something like that. But maybe we should focus on evaluation, because risks can be managed via evaluation and certification, and we do it regularly. I have to pay my fee every 2 years to the HCPC for the privilege of being registered as a clinical scientist. Nurses and doctors have to do it on their time, submit portfolios and stuff like that, because that's how we manage the risk of patient exposure to healthcare professionals, so to say. We look at their qualifications, we evaluate their safety, we check whether they're criminals or not, and things like that. And we have similar processes for drugs and medical devices. We have, the HMRA, we have NICE, we have recommendations, certifications, and so forth. And the same goes for labs. There's quality assurance processes in place for labs, for point of care testing. And we don't really seek patients' consent to each of those specific things. Of course, there is a problem, especially if we look at the more subjective standard of consent, and that some of those products that we generally deem as appropriate for the use of care might not be for some groups. Again, thinking about an example here of vaccines, and some are developed on eggs, some have porcine products in them, some are developed with cell lines like HEC293 that are a bit more controversial among certain groups. And even though these vaccines might be approved, these are still things that we inform patients about because we know they might not want to give consent to that. And then a final question that builds in my head, when musing about this is what's the deal with consent and AI and the disclosure thereof? Because generally we use the consent process to gain permission to carry out a specific investigation or therapeutic procedure. We don't scrutinize with the consent process the way that the decision maker makes those decisions. Sure, the consent process makes certain demands of from the clinician whomever is obtaining consent, but we're not scrutinizing the clinician, nor how the process of reaching a decision, whether it be through an MDT or not, has been made. Not that those things might not into play sometimes, just to make sure that due diligence was taken in the care of the patient, but primarily the consent is just to undertake the procedure, whether be it therapeutic or investigative. And now, before I reach the conclusion, I'll just go back briefly because I forgot to mention why the case of cybersecurity and electronic patient records was important. One of the reasons is that if we don't collect the data appropriately, and usually that requires some kind of electronic system nowadays, we might not meet the relevant reporting criteria. So for example, for ICNARC, if I'm not mistaken, nowadays you have to give the highest and lowest blood pressure that a patient had within an hour, which is very different from recording things every hour. So without this digitization, we're not meeting the appropriate standards of reporting and potentially of care. And if that holds true for how we gather the data from patients, it might well relate to some future standards to AI. I apologize for not mentioning that earlier. Anyway, up to my conclusion. I don't think the use of AI in healthcare seems to create any new issues in relation to patient consent. It just brings a lot of old ones to the attention in a new frame. The issue about, how much information do we give patients and how free is their choice in making those decisions are pretty much the same as there would have been. I didn't want to focus too much on GDPR, but it seems that it might be overly burdensome or at least impractical to apply, especially when AI's use in healthcare becomes a bit more common. But perhaps this digital revolution, or however it's called, is just an opportunity to reevaluate how we do healthcare, so to say. You know, should it be a prompt to reevaluate our practices? But then it means that whatever we decide based on looking at consent for AI enhanced healthcare should overspill on other aspects of informed consent and how we treat patients. And obviously, there's a big difference between regular disclosure of the fact that AI is used and denying patient information that's being asked explicitly or lying about its absence. As I said, not everything that we talk about that we could tell patients about, we do. One example that I'll just give to this, just to expand on sources of information that a clinician has, is from the work of Cohen, who gives an example that clinicians learn things on their lectures, through medical journals, through a random chat with a colleague over lunch. And these are things that we can't even pinpoint often why we know them. And we don't necessarily expect patients to interrogate. So I'll close now. I hope I haven't mumbled too much, and I'm open for questions. Thank you.
Well, thank you very much, Michal. It was a brilliant talk. I do have a question, but I'm going to pass this over to the audience first. Does anybody in the room have a question or any? Right, we've got a question here. Yeah.
Hi, my name is Vaughan, and I think that there is a potential issue here in that patients might have many rational reasons for wanting to know that AI has been involved. They might, for instance, have read famous philosophers writing on superintelligence and how all of this is very bad, and they might have been convinced by these philosophical arguments, or they might have other reasons. But if we don't disclose, they will never have an opportunity to think in that way. And then I also think that at one point you said, well, if something is very risky, you might not do it. I just tend to think that's wrong, in the sense that if you have locally advanced pancreatic cancer, you can have a Whipple operation. It's one of the largest operations anyone can have. It's highly risky. It doesn't increase average survival. But if you don't have that operation, you will definitely not have long-term survival. So that's just one example that in healthcare we offer hugely risky things to people if that is the only option.
Could you hit that? Okay.
I hope so. I struggled a bit with the first half. I'll deal with the second half, and then I'll maybe need clarification for the first half. So, okay, I probably perhaps should have said it more precisely, but I guess risk in those situations is relative in that you can have a highly risky procedure because the risk of not taking the procedure is also high, like in the sense that you wouldn't be offering some kind of very risky procedure with a high rate of mortality if somebody had an ingrown toenail. Your risks of the procedure are usually proportional to the disease you have, in the sense that looking at other things, like maybe if somebody is 90 years old, but you might still consider operating on their heart if the chances of them dying with without them having the operation are higher, potentially higher than with. So in this sense, risk is proportional, but you wouldn't do something very, very risky for something that, an ailment that's otherwise really, really minor, so to say. So I'll put this clarification forward. And I do feel the the argument that like, oh, if you don't tell people, then they have like no opportunity to learn or to object about these things. But and I think that's what I try to show throughout the talk. There's a lot of things that we don't tell people that perhaps they would also want to object to. And is it that the fact that AI is being used in their care, does it fall into this broad category? And that, like members of the public nowadays, with all the hype that there has been about, are probably suspecting that perhaps there might be AI used in their care processes at some point. So perhaps those who really want to object can ask the question up front. It's like my musician case at the beginning. That's a person who has a specific interest in preserving their hearing, and we treat them differently than your average normal reasonable patient. And that's the general thing that we do up front, is we have this reasonable patient standard in the place that we think that our current patient is. But then we have also that specific standard in the sense that we know that there's something different about that patient because of their background beliefs or whatnot that would make it significant. That would give us good reasons for making those disclosures up front. But I don't think that just because some people might, doesn't mean that we have to do it with every single patient, because otherwise we would be asking people really a lot of questions every single time. Nick, does that answer the question? Maybe not satisfactory, but
I tend to think it's a false dichotomy, in the sense that if a concern is sufficiently widespread, then we have a reason to disclose. And there are a whole range of reasons why people might want to know certain things about the AI that's being used in their healthcare. They might not like Palantir. They might not like Meta. They might not, and there seem to be perfectly reasonable reasons for holding it. Whether they're the correct news is a different question.
yeah. Mm-hmm. Sorry, go ahead.
Yeah, it's not that we are trying to accommodate sort of very narrow idiosyncratic views. We're trying to accommodate views which are reasonably widespread.
Okay, so if it's reasonably widespread, then perhaps that falls under a reasonable patient sort of standard. But I think the other problem with that is that if patients have like really specific concerns, like they don't like Meta, Google, whatever, then one of the things that we should look is, going back to my evaluation and certification, is how do we ensure that we're not always participating with the main offenders if there are good alternatives to that. But that might be tricky, and we don't want to hinder innovation either. But then if we give, because it's quite difficult if you have like X amount of patients who each have a good reason, but they're different reasons, and to whom we would have accommodated differently. The other problem with that is what's the alternative that we're giving them. Because if we, again, move a bit, maybe a couple of years into the future, and these things become standard of care, then if we can't offer them an alternative, then we can't really get free consent from them. It might well be informed, but it cannot be free. And as I said, everyone loves talking about informed consent, but consent needs to be free and informed to have the whole package. And is it reasonable for us not, to require the institutions to have alternative processes? Like if you have an EPR in your healthcare system and you're averse to just digital, because that data might maybe go to Meta or whomever not, because the government will decide to sell it, or something along those lines, then would a hospital really create like a specific paper-based folder, for just that one patient? Like, is it feasible? Is it reasonable? And the more processes we have that are digitized, the more alternative processes should be in the way. So I don't think the demand from WHO that alternatives are present will be always feasible. So I think we will run into a problem one way or the other, because that's life. But I think that I'm not sure whether that necessarily solves the issue that you state.
I'm going to have to say, because we've actually now 5 minutes over our time, and people have got to disappear and so on. But thank you very much for your question, and it was a brilliant talk, Michal. Thank you. I mean, we were never going to get a completely, a single answer on this today, and I've got questions I could ask you, which I might ask offline. But thank you very much for taking the time to join us today and give this talk. Maybe you want to look at it again in the future, because I'm sure as time goes on, this is not going away at all, and it's going to change as time moves forward. So, Michal, thank you very much. Really appreciate it.
Thank you. Bye-bye.
Thank you, everyone, for joining us today. If you aren't on the mailing list for the seminar series, send me an email. My email is john.parkinson@manchester.ac.uk. Happy to get you on the mailing list. Thank you all to who joined us in person and online, and we will see you in the new year. So thank you very much, all. See you soon. Cheers out.